Okay, we're going to go ahead and get started because Dr. Williams has quite a bit of great material to get through with you today and wants to leave some time for questions at the end, and she can stay on a little longer for people with continuing questions. For those of you who don't know Dr. Williams is the medical director for our New York City TCTTAC Center, and she's also professor of psychiatry at the Robert Wood Johnson Foundation, a medical school, and director of Division of Addiction Psychiatry in New Jersey. Dr. Williams is an expert in tobacco addiction and treatments and has conducted several biobehavioral, translational, and clinical trials regarding smoking in individuals with serious mental illness. She has extensive experience leading training sessions and providing technical assistance with us through TCTTAC and through the rest of her long career, and designing organizational change models to promote smoking cessation at behavioral health agencies. So with that, I would like to turn it over to Dr. Williams.
Thank you so much, Nancy, and great to see so many people on the line with us today. This is going to be a broad overview of various aspects of treatment for tobacco. This is my disclosure information, and you can see that the handout is also available if you want to have copies of the slides. So today, this afternoon, we'll go over some of the evidence-based treatments for tobacco with an emphasis on counseling and psychosocial approaches. We'll talk about how to put together a plan to help someone address their tobacco use disorder, the supports that are often necessary for people to be successful, how this might translate into a treatment plan document, and also talk about once people start the initial process of quitting, how we'll help them cope with cravings and think about a relapse prevention plan. So I'll just start with a case. This is a real case of a gentleman who was referred to me actually for depression. So I still see some general psychiatry cases. Interestingly, this gentleman had never been in prior treatment. He had a history of depression, childhood trauma, PTSD, and chronic pain. He was quite a complicated patient, and he was essentially referred by his surgical team. They had known him for years because he had so many vascular surgeries and procedures, more than 20, basically on every blood vessel in his body. He had never been able to quit smoking for this 20 or 30-year period, despite having a lot of medical illnesses. I tried to estimate the cost of his surgery, although it's impossible to do so. It's clearly in the millions of dollars. So as I treated him for depression, I asked him about his tobacco use as part of the overall approach. He said, I'm not really interested in stopping smoking. I don't really even believe that it's related to my vascular disease. I said, okay. We focused on working on depression. He got treated with duloxetine and bupropion for his depression. What was interesting is even though I had briefly mentioned it and done an assessment the first visit, and he said I wasn't interested in stopping smoking, he brought it up in subsequent visits, actually pretty quickly. He asked me on the second visit or third visit, what was that you were saying about helping me with smoking? Tell me about nicotine replacement. He opted to try the patch and gum. And within the fifth visit of me knowing him, he made a quit attempt, and he's basically remained smoke-free now for more than 2 years. So I just point out this case because this is kind of an interesting example where, as a behavioral health professional, I think we can lend a special expertise. This is somebody who had been in the medical system essentially for decades, and no one had really been able to help him turn the corner and address his tobacco. And I think it's interesting as part of an integrated treatment approach that he was actually very successful. So how do we do this? How do we treat tobacco in our patients? And certainly I'm going to touch on some of the themes today, but essentially I believe we all could be doing something, even if it's a brief approach. So even brief assessment can sometimes have a clinical impact, just talking about it. I think framing it as treatment and not cessation can be useful. I think sometimes the language we use in talking about this issue with patients can feel so final and so scary and overwhelming for them that sometimes if we just approach it like everything else, why don't we give it a try? What have we got to lose? Could we take some small steps? Could we think about adding medication? Could we think about it like a co-occurring disorder? I think sometimes that helps to take the pressure off patients. It's not a finality. And it may be more engaging overall and encouraging more people to participate. Again, there's lots of examples for how we do brief intervention. So in some systems, it may be that we are not the primary counselor seeing the patient, we're doing assessments, or we have a much briefer role with patients. And I think even when your role is quite limited, there's a lot we can do in terms of brief intervention. This is the model for primary care. It's called 2 A's and an R. It's basically saying that every single healthcare professional can do at least this. Everyone can ask about tobacco. Everyone can provide very brief, specific advice. I think it's in your best interest to consider stopping that tobacco at some point. And everyone at the very least can provide referral, linking people to a colleague or to a service where they can get more information. So at the very least, we can all be doing 2 A's and an R. But in this webinar, I'll talk about a lot of the next steps that you might also consider. When we think about this addiction, tobacco use disorder, I want people to kind of keep in mind that it's pretty hard to stop smoking. This is a pretty insidious addiction. Tobacco is widely available. It may be accepted in many treatment settings. So although many people say that they want to stop smoking, in fact, it can be quite difficult to quit. And the numbers, the success rates are lowest when people quit without treatment. So another way in just thinking about framing the message is rather than say to people, you ought to quit smoking, it's a very different message if we say you ought to quit smoking with treatment. Because we know that treatment elevates the success rates to at least 25%. You might look at that number and say, well, that seems discouraging. That's not a very high success rate. But that success rate is similar to other substance use disorders and chronic diseases. The truth is that we're not really curing that many people with bipolar disorder either, but we don't give up. It's a chronic disease, and we do the best we can. And it's similar with outcomes from tobacco use disorder. Why is it so hard to quit? Well, it turns out that smoking a drug is a pretty highly addicting way to use drugs, that the delivery of the drug to your body matters. And smoking, in fact, is one of the most addicting or rewarding ways you can deliver drugs to your body. So smoking, the behavior, is actually a part of this problem. In addition, you might think that treatments are actually quite limited. There's only a few medications that we know work. Most places, when they give you counseling to help you stop smoking, it tends to be quite brief or limited. And there's no levels of care, which means even if you failed the treatment 100 times, we don't really have more to offer people. In addition to that, we can't even get people to use the treatments we have, so utilization is still not where it should be. Most people will say that they don't want the counseling, they don't want the medication, or they use them in too low a dose or for too short a time. So again, a lot of what I do is really convincing people and educating people about the benefit of treatment, the need for treatment, defining what that is, how long that's going to be, and how that can make all the difference this time compared to other times when they tried to stop smoking. These are the predictors of successfully quitting. And as I go down this list, you can imagine that often our patients have the opposite of these characteristics, which means it's more challenging often for people with mental illnesses to stop smoking. So being less addicted, having a higher socioeconomic status, having an older age, having fewer smokers in your network of friends and family are all associated with having it be easier to quit. Not having a behavioral health condition makes it easier to quit smoking. So again, unfortunately, these are challenging in that our patients have many of the opposite of these, suggesting it's harder for them to quit smoking. You can see, though, the one on the list that we actually have the most control over that we could manage is the use of treatment. The use of treatment really greatly increases the chances that someone can successfully quit smoking, and that's where I would suggest we focus our efforts. When I say treatment, what I'm referring to is both counseling and medication. Both are effective, although in this webinar today we'll focus mostly on the psychosocial approaches. In terms of how we provide people counseling with regard to their tobacco, there's several types of interventions that we use. We may use motivational interviewing to try and engage people or get them motivated about this. There's a physician brief advice that comes from a healthcare provider, brief advice to quit. Someone could be involved in telephone counseling services. But really I'm going to focus on group therapy and individual counseling today. These are actually all proven effective, but as you can imagine, for more challenging patients, it's usually assumed that a more intensive counseling approach will be more helpful. As I mentioned, both medications and counseling are effective in terms of strategies to help people to stop smoking. But what we want to recommend is that people get the benefit of both. Ideally, we would want people to get both medication and counseling to help them stop smoking because that's associated with the highest success rates. Some people may only want one or the other. That's okay. We have to work with people where they're at. But the truth is that the treatments are most effective when given in combination, and that's generally our recommendation. These are the kinds of approaches that are evidence-based in terms of providing effective counseling. It includes aspects of skills training, relapse prevention, problem solving, coping skills, and stress management. Those are all components of an overall successful counseling approach. What these things have in mind is that they help people to change their beliefs or their thoughts, their cognitions about smoking. It reinforces non-smoking behaviors and helps people avoid high-risk situations. So these are the general strategies that are involved in a successful counseling approach. What's interesting about those strategies is that typically this is the same skill set for people who work in behavioral health, that we are often very adept at these forms of counseling, and we're using these very same counseling strategies in our other work. Which really underscores that behavioral health providers are really well suited in many ways to provide tobacco counseling because it's the same type of counseling that we provide for other disorders. There's actually tremendous similarity in the overall approach. And when you think about all the people on the treatment team, we could imagine that everyone plays a role. And the more times people are hearing the message, or the more that the message is really common across a range of services or across levels of care, the more effective our overall approach is going to be. So really everyone on the treatment team ideally plays a part in this message of supporting the tobacco-free lifestyle. It's not just the counselor who's providing the sessions, but really everyone on the treatment team plays a part in terms of supporting the overall goals and sort of keeping the plan. And even those brief supportive comments that other people on the treatment team make seem to help and can have an overall stronger result. In terms of individual versus group, they are both effective strategies, and you can choose the one that either the client prefers or that is more suitable for your environment. So individual counseling allows you to really tailor the counseling to the person's needs. It can be more personalized. It may help a therapeutic alliance where you're really working one-on-one intensively with the patient. It can be helpful for people who don't want to attend group because of paranoia or social anxiety or other factors. So that's certainly one possibility to provide individual counseling. But you also could provide group counseling, and again, they're probably equally effective for this. Group counseling has advantages of being efficient in terms of your time. It's cost effective for the treatment center. You know, I really like group for this problem. It's accepted often by the patients that we see in our treatment settings. And the support that comes from a group counseling intervention is often quite profound, the effect of the peers on each other. So I think it can be quite powerful. And typically when I run smoking treatment groups like these and one person is having success, there's a lot of excitement that gets generated in the group and almost like a contagion, and then sort of everybody wants what that person has, and then other people get excited. Maybe they could see themselves quitting someday. So I think that sort of modeling of success and coping can be really powerful in the group setting. Telephone counseling is certainly also an option. All states offer free or low-cost telephone counseling, and certainly this is also available in New York. On the telephone counseling service, typically the first call is an assessment. The person on the phone is really a skilled tobacco counselor, and they might be on the phone with you for 40 or 45 minutes conducting a thorough assessment. Then they would talk to you about setting a quit date, which might be in the next 2 or 3 weeks, and then they would arrange a series of brief follow-up calls. You could think it's a great service because it has no cost associated with it, so you don't need insurance. It's available in multiple languages. You don't need a babysitter. You don't need transportation. So there can be lots of reasons why this is a great service. On the other hand, for clients with serious mental illness, there could be challenges that make it difficult for them to actually utilize this service effectively. For example, sometimes people don't have a phone, or they have unstable phone service, and that could be a barrier. Some patients could be paranoid and mistrustful of this counselor that they don't know or can't see. The follow-up calls can also often be provided by different people. You don't necessarily get the same counselor every time. So although this is a service, sometimes it comes up that there are concerns for people with serious mental illness, that it may not really be tailored to their unique needs. And again, that's where it comes back to the idea that really the treatment team that works with this person and has the best relationship with them are probably in the best position to help address the tobacco use. But keep in mind, QuitLine could be helpful for higher functioning clients. Certainly we should use it for employees, encourage staff who use tobacco to use this service, or our family members. So it can play a part in the overall addressing tobacco that your agency may have. In terms of thinking about the quitting process, we can really break it down into 3 unique phases. We often talk a lot about the engagement phase, getting people ready to quit, educating them, and getting them motivated. And if you've been to any of our trainings previously, we spend a lot of time talking about that very important part of the treatment phase. I'm not going to really speak about that today. I'm going to focus on the next phase, which is really how do you, now that someone says they're ready, I'm ready to make a change, Dr. Williams, what do I need to do? Really focusing on some of those specific steps of starting the process and then helping people to avoid relapse. So when we think about the actual quitting smoking process, there are a few steps that we often think about. We help the person really think about a specific and often a detailed quit plan. What's this going to mean for you? When do you think you want to try to quit? How can we help you to get ready for that date so you can be more successful? How can we help you get through the first day or the first 3 days when we think it'll be the most challenging? And how can we think about getting you support and also framing this as a positive event? This is not a funeral. This should be a celebration. And so kind of reminding people of that and building that into the plan can be helpful. So I'll focus for a few minutes on some of these steps. So if someone has made the decision to try to quit, we often ask them to try and make a commitment to a specific day. We think that that's helpful. And it may not be that the day is today. The day may be 2 or 3 weeks away. So, and you can talk to the person about negotiating that day, what would be most helpful for you. Should it be a Monday? Should it be a Friday? Are there pros and cons of one day versus another? But if that day is not going to be today, what can we also do in the meantime? Well, we can do some things in terms of being aware of our behavior and maybe making some small steps to help us to be mentally prepared for that quit date when it comes. Maybe we can stop buying enormous purchases of the drug, because ideally you'd want to be running out of the drug of tobacco on the time that you want to quit. You might want to also change your environment in the interim. Maybe it's time to clean your house or wash your clothes, because you want to be able to have the environment free of cues and triggers to the extent that it's possible, whether that's ashtrays or clothes that smell like smoke. And so are there things you can do to clean or prepare or to begin to remove some of that paraphernalia from your home? Because as a non-smoker, you won't need 50 ashtrays in your house. And maybe those will be things that would cue you to want to smoke. And would it be helpful to start getting rid of those things now? Preparing to use medication is an important part of this step. We know that medication increases the chances that someone can be successful. So maybe they're not aware of the 7 different medication choices. So we would want to spend some time educating them about that, saying, which one do you prefer? How will we help you to get a prescription for those medications? Will you need to see your doctor? Remember, even though the nicotine replacement is typically an over-the-counter medication, we often want people to get a prescription from their prescriber for those medications so that they can get it free with their New York Medicaid. So again, we have to prepare that step. There might be an appointment that's necessary to help make the medications available. In preparation, we often want the person to be thinking about who's going to help you through this process. How are you going to get support? How are you going to tell people that you're planning to do this so that you can have support when you need it? So we might have a few counseling sessions before the time that someone is about to actually quit. It could range anywhere from 2 to 4 sessions where we're actually talking about this preparation and planning to quit. And if any of you are familiar with the Learning About Healthy Living manual, we usually emphasize Group 1. There's actually 2 separate group treatments in the manual, and we often talk about Group 1, which is the engagement or motivational group. What I'm showing you now are actually handouts from Group 2, the second group treatment, which is also available in the same book, which is much more focused on the act of quitting. So there are handouts that you could use either in a group or an individual format to help you to do some of this work. This one is specifically called Making a Plan to Quit. How are you going to do that? What are going to be the steps that will help you to be more successful? So sometimes these tools or handouts can also be very concrete, reinforce some of the ideas, and help you to do these sessions with patients. In helping somebody prepare to quit, it's often important to take a more detailed quit history. So rarely are you seeing somebody who's trying to quit for the first time. So what was your last quit attempt like? Did you use any strategies to help you quit at that time, like counseling or medication? How long were you able to quit? Did you have significant tobacco withdrawal symptoms? Did you use medication? What was the dose? For how long? Because the more you learn about this in terms of understanding this quit history, you could really sometimes identify the things that may have undermined the success. Often it's that the person didn't use enough medication, or they felt very discouraged after 3 days and they sort of gave up. They might have not had a support or counseling plan in place. Or there might have been other environmental triggers that sort of undermined their attempt. So how could we plan for that in the future to reduce the risk for relapse? In terms of the quit date, again, is a specific calendar date. I remember when I first started doing this work 20 years ago, I remember thinking that was kind of odd because you don't set a cocaine quit date. The assumption is kind of the first time the person shows up is the quit date, but it's done a little differently here where the person might actually plan ahead a few weeks and make a commitment to quit on a specific date. And again, you could negotiate with the person if it makes more sense for them to quit on a weekday. We typically find it's more helpful on a weekday, typically because you could see the person for a brief appointment on that day, or at least have a phone call contact for some brief support. Contact around the quit date is associated with greater success, so we often try to steer people to a weekday. But someone may say, well, my birthday's Saturday, and it has to be Saturday, and you say, okay, well, that's okay. But we sort of talk about that in terms of the pros and cons of picking a day. The rules are that typically we allow the person to smoke as usual up until the time of that date. They don't have to cut down on their smoking. In fact, we worry that that could actually bring on more withdrawal symptoms. But really the commitment is, okay, on your quit day, if it's next Wednesday, you're going to promise essentially that Tuesday night is your last smoking. And when you go to bed on Tuesday night, you really shouldn't have any drugs left in your apartment or at your home. So I don't care what you smoke on Tuesday, but you know the assumption has to be that when you wake up Wednesday morning on your quit date, there's no drug in the environment, because that will certainly undermine people's success. So we really talk about that, and really getting rid of tobacco is an important part of this. Or promising to not go to the store where someone might buy tobacco to try and avoid those early cues and triggers. Again, having a brief appointment on the quit date or even a telephone call is associated with greater success. Checking in with the person, how are you doing? Did you put the patch on today? How's it going? And again, trying to frame this as a celebration, that this is a really positive step. Even if it ends up not going so well, we're so proud of you for even trying to take this step and to try and better your life, and that's really cause for celebration. Now, it's interesting because sometimes people don't really like to set a quit date. They say that they would rather reduce their smoking over time. And people have looked at some of the outcomes of what happens if you set a quit date versus if you just try and reduce your smoking over the next month. And the truth is that the people that actually commit to a quit date end up being a little bit more successful overall in quitting. It doesn't mean that some people can't be successful by reduction, but when you compare the people that reduce to the people that actually make the commitment to quitting on a singular day, that the quit rates are ultimately better in the people who are having a quit date. That's why we encourage that kind of approach. So again, this is what we're doing in the preparation sessions. We're talking about what this means to have a quit date, what's sort of expected in terms of how our best chances of succeeding, that we're thinking about getting rid of tobacco and paraphernalia and having all these things in place and having a support plan, and really, again, reinforcing this with a handout or a real concrete example of this plan. We often tell people, when we write the quit date on this piece of paper after we've sort of negotiated it, we'll tell the client, go home, put this on your refrigerator, share this with your family, make sure your roommates know, tell your other members of the treatment team, try and get support and involve everyone else in this plan so that people don't inadvertently undermine your success and offer you cigarettes or whatever could happen, and generally support your plan. So try to make it very real, but also sharing the information with others. And again, sometimes people aren't really ready to quit immediately, and that's okay too, and we still want to work with them. So there's examples like this of a handout where even if someone is not willing to quit immediately, they might be willing to take some other steps, like make smoking more difficult for them, or think about the reasons why they might someday want to quit. And these can be ways to also keep people motivated and engaged and feeling positively about this, even if they're not ready to really make a quit date or that kind of next step. So lots of other ways you could measure sort of smaller behavior changes as a way to stay positive and keep people moving forward. Okay, we said medication is an important part of the overall plan for success. We want to educate people. There's various choices that they may have for medication, pills versus nicotine replacement options, but we do want to encourage people to have a medication as part of their plan to help them to be successful. Keep in mind some of the medications, it's recommended that you start them 1 to 2 weeks before the quit date. So again, that's why this preparation is sometimes needed, because you would want to be starting your bupropion or your varenicline 1 to 2 weeks before the quit date. You don't start those on the quit date. You have to start them before for them to be effective. So the preparation is sort of, some planning is involved in this. And again, really educating people that, people say, well, I'm on too many medications already, Dr. Williams, I don't really want to take this nicotine replacement. And I said, well, you know, I want to educate you about the symptoms of withdrawal. It's very uncomfortable. Most people can't tolerate it. That's the reason that often people go right back to smoking in the first 3 days after the time that they want to quit. Cold turkey is bad. People sometimes think it's the right way to do it, but in fact it's the least successful way, and it's the way that actually causes the most suffering. I tell patients, I'm the no suffering doctor. I don't want you to suffer. I want to give you enough medication that you're really comfortable in this process and that you can really be successful. So again, educating about that. And this is one of the handouts again from the first group, Group 1 of the Learning About Healthy Living Manual. But you might go back to that and use these as tools in terms of educating people about the need for medication. And again, these handouts are in the manual in terms of reviewing the kinds of medications that are available and the benefits people get from using medications, like they're twice as likely to be successful in quitting, they have less withdrawal symptoms, it'll reduce cravings or urges to smoke, it'll make your mood better when you're stopping smoking, and they're also associated with less weight gain. The people that gain the most weight are the people that quit smoking without the aid of medication. So just reinforcing some of these older ideas. Okay, I said celebrating quitting is really an important part of what we do. So we might make paper certificates and give them to people on their quit date, because even if they only quit for 1 day, we're very proud of them for taking this step. It may be the first time they've ever quit for a day. We really want to celebrate this as an accomplishment. And nowadays with computers, it's pretty easy to do things like this and make certificates to really acknowledge that people are making changes in their lives. So a lot about celebrating, and sometimes that it's talking about, you know, what can you do with the money that you're going to save? Would you save it up for something to reward yourself? There's ways you can build in a reward or positive benefits of this so that it really keeps people focused and on track. So once people go through the first day or the first step of quitting, the initial quitting, in some ways you could think of, well, that's easy compared to the relapse prevention, which is how do I never go back to it again? Lots of people try to quit, but how do you really stay quit? And again, this can really be challenging and may require considerable more support and counseling sessions. And again, that's when you understand that these brief counseling approaches may not be enough for people with serious mental illness, and they might really benefit from an extended period of relapse prevention counseling. Really talking about the cues and triggers that bring me back to smoking, how can I avoid those things, and this is a problem solving. This is a cognitive behavioral type of approach. What's the problem? How do we think about the solutions? What are the pros and cons? How do we create a plan? And that's really what relapse prevention is about, which, as I said, is a part of cognitive behavioral type strategy. It's going to be very common that people are tempted to smoke. And what you want to do is really frame it as a lapse. How can we minimize the damage when people smoke? How can we make sure that it stops at a lapse and doesn't go back to a full-blown relapse? So People might have a puff of a cigarette or a single cigarette or a day that they smoke. But how can we identify it then when someone's in a high-risk situation to help them to turn it around and to get back to a plan of quitting, get back into treatment? Can they call their support person, reach out to their doctor, talk about it in group? Unfortunately, this is when we really lose people in the treatment. People are so ashamed that they have suffered a lapse or a relapse, and they feel like a failure, and they experience a tremendous amount of shame, and it's really difficult to get them to come back. So we do a lot of outreach calls. Normalize this. It's really common for people to lapse. It's part of the process. It's almost expected. Can we get you to come back and we'll try again? Can we learn from this experience? So a lot of lapse management and helping people to continue to try again. Craving is an important part of the process. So how do we think about identifying the craving? Sometimes people get so overwhelmed and nervous about the idea that I'm going to have urges to smoke. And again, trying to normalize that's almost expected. That's your brain having a memory of smoking, which is not really that surprising since you've been doing it for 40 years. So your brain's having a memory of using the drug, and what can you do to sort of ride it out? Some people call it urge surfing. How can you relax and distract yourself, or get your support person, or think about all the reasons that you wanted to stop smoking in the first place, using self-talk to help support you through it? What's other coping strategies that you use for other aspects of your illness or problems that help you, and can you also use them in this situation? Again, trying to normalize the behavior, not put the blame on people, reduce the shame that's experienced, and helping them to recover and try again. Support ends up being a really key factor, and for people with serious mental illness, this can be a challenge to identify ways that they can get effective support. And I'm thinking about support really from people who are not tobacco users, ideally. So if you're providing the treatment in a group, then obviously the group members and you as the clinician can be ways that the person accesses support. But we want to be creative and think about all the other ways that the person could gain support outside of even the treatment environment. Are there peers within your system that could also be support people for people working on tobacco, people who maybe have quit smoking for a few years that would love to have a job or a leadership position in your organization, having sort of even an informal sort of drop-in peer support group to help others who are struggling with tobacco. So that's one way to think about it. Certainly friends or family who don't use tobacco can be a great source of support. The internet can be a great source of support. I have been surprised many times by clients who I didn't think seemed that well organized, that were able to really access internet supports fairly effectively, whether that's a chat room or logging into a certain network where people are emailing each other or providing support through the internet, which can be helpful in the middle of the night or times when the treatment agency is closed. Sometimes people can use other 12-step as a way to gain support. So there is a smoking version of AA, which is called Nicotine Anonymous. And if people want to attend that for support, that might be okay. In reality, I find that those groups, though, are very scarce. They're very hard to plug into. They're not as established as AA and NA. So in reality, it might be difficult to actually access a Nicotine Anonymous group for support. When I've worked with clients, though, that had prior substance abuse problems, they often say that they can go to their home meeting. So if they're attending AA or NA anyway, they can often use that group meeting as a way to get support for them to stop smoking, especially if their sponsor has also stopped smoking, because the themes are the same, the concepts are the same, And so sometimes people can rely on their home group if they've already been involved in that kind of 12-step experience before. And support, I know that the term sounds so general, but it is general. It's not necessarily treatment. It's just sort of kindness and assistance and just saying, you know, I'm here for you. Sometimes it's a safe place where there's no smoking. So sometimes we really think about where are your safe places that you can go, where you can avoid smoking behavior, whether that's a library or a smoke-free restaurant or a relative's house that doesn't smoke. So sometimes that's also a form of support just in terms of a safe area. So it can be lots of things that fall under that umbrella of support. And the more support someone gets, in fact, the more successful they will be. So this turns out to be an important characteristic in the overall success. In terms of how we implement all of this and integrate it into our work in behavioral health, we might, and I would encourage you to think about including this in the treatment plan. If you're working on this issue with somebody, we should really document it in the plan. We should begin to acknowledge tobacco use disorder as a problem, and that means writing it down, including it on the problem list and treatment plan. Again, we can always do assessments, even if we're not able to do intensive treatments. There can still be a benefit, a clinical and therapeutic benefit from assessment where we're documenting someone's level of dependence and how they feel about changing this behavior. That's another way of integrating it into our practice. And then in terms of really formalizing it in the treatment planning process, ideally we want to be thinking about long-term and short-term goals, things we're discussing with the client, client-centered goals. I know a lot of places use the client's language specifically, but how would the client really conceptualize short-term and long-term goals with regard to tobacco? And how can we include that in their plan? And how is that maybe even consistent with other goals that we may be working on with them? So I often have the experience when I'm working with people in behavioral health and doing a training that people say, well, I don't really know how to write a treatment plan for the problem of tobacco. I never did that before. I don't really know how to do that, which is kind of an interesting observation because if you've done any type of substance use work previously, it's actually quite similar. So these are examples of other substance abuse treatment plans that I extracted from a chart review study. So these were real-life examples where a treatment plan basically said that a person relapsed on cocaine and heroin. That was the identified problem. The goal was to abstain from mood-altering substances, understand the disease concept of addiction, recognize sobriety as a lifelong process, and the objective over the next 30 days was that the client would identify 2 triggers to substance relapse and 2 coping skills. Kind of a nice treatment plan. I think it's pretty standard kinds of language that we think about in these types of problems and plans. What's interesting when I look at this kind of a plan is that it doesn't even actually say that the person wants to stop using cocaine and heroin. I point that out because although I think motivation is obviously important, I think sometimes we get too hung up on it with regard to smoking. When people present with other problems, the wheels are in motion and we often start to initiate treatment. We don't get so hung up on exactly what the patient said or what their specific words of motivation were. And sometimes I think that can be a barrier to us doing effective tobacco treatment if we get too hung up on listening for specific words. When people have a problem in lots of other ways, we often initiate support and treatment in various ways. And I think we could think about an approach to tobacco that's similar to that. So when I look at treatment plans like this, I say, well, to me it looks like you could really replace the names of those other drugs with the word tobacco. And in a lot of ways that could work as a treatment plan conceptually. Here's another example where the person is, again, had been using alcohol despite negative consequences, and the goal was to stop using alcohol and to stabilize medically, psychologically, and socially. And then the objective over time was to think of 3 specific examples that the alcohol had had on their life, their health, and psychiatric stability. And in this example, I'm literally changing the word of alcohol for tobacco to show that really treatment planning is quite similar across problems, and these kinds of examples really work for tobacco, that a person could be using tobacco despite negative consequences, and even if they are not immediately ready to quit, there could still be things that we're working on in terms of helping them have greater recognition, greater understanding of the problem, the way it's impacting them, etc. So alternatives to just a quitting kind of a treatment plan. And again, so there might be long-term goals versus short-term goals. The long-term goal for someone may be eventual abstinence, even if they're not wanting to quit today. Maybe that's still a long-term goal for somebody. Maybe a long-term goal is to change their stages of change, to help them move from pre-contemplation or contemplation towards preparation because they're not really ready today. Maybe someday they'd like to make a quit attempt, but they're not immediately ready, but okay to sort of acknowledge those as long-term goals. So if somebody's not really ready to quit, again, maybe there are more short-term goals, increase their motivation about quitting, again, helping them move from one stage of change to another in the shorter term, helping them to become aware of consequences of tobacco. That could be a reasonable short-term goal, identifying 3 consequences, understanding the need for treatment and how treatment helps you to be more successful in quitting. A short-term goal might be to attend an engagement group or treatment to learn more about the impact of smoking and the promise for treatment. So just different ways to think about examples, and I'm sure you would have lots of good examples as well for thinking about how you might integrate this and the language that you might use in terms of treatment planning. Other examples of short-term goals might be to help somebody comply with tobacco-free policy. So perhaps they're in a residential program where there's no smoking allowed, and they're really struggling with that. And they say, well, I don't really want to stop smoking. And you say, well, I understand that, and when you leave here, you'll certainly have a right to do whatever you want, but how can I help you while you're here to be more comfortable, to be more successful, and to comply with the rules while you're here and sort of make the best of it? And that can be also a short-term goal. Another short-term goal might be to use medication, again, even in the short term, to reduce temporary withdrawal symptoms, to reduce craving. So somebody's admitted to the inpatient unit, say, for 5 days. And a short-term goal might be, well, let's help them to use medication during that time to reduce the uncomfortable symptoms of tobacco withdrawal. And then they could also learn about what that experience is like about using those medications. Maybe just learning about the impact of smoke on other people in the environment. So I'm sure we could think of hundreds of different short-term goals that people could be working on, even if they're not committed to abstinence initially. A lot of this field of working with people that use tobacco is changing, and increasingly people are getting away from this idea of cessation language and this idea that you have to quit forever, because that can be so overwhelming to anyone who's struggling with tobacco addiction. And it's interesting when you think about that, tobacco language has very much been framed in this idea of quitting forever. And yet alcohol treatment, or AA, was always framed as 1 day at a time. And when you start to talk about something 1 day at a time, why not quit for a day? Why not quit for a few hours? What would that experience be like? Could you save some money? Could you try some free nicotine replacement? Could you feel better? Could you practice a new skill just for 1 day? Try other coping, not have to go outside in bad weather. So lots of ways where I think the field is also changing to try and be more engaging, more inclusive of people, try and reduce some of the barriers and the fear that people have, that they feel like they can't commit to forever. Okay, well, can you commit to a day? Let's see what that's like. What do you have to lose? I'll prescribe you some nicotine, and if it goes really badly, that's okay. Come back, tell me what it was like, what was good, what was not so good. We can learn from that experience. So again, a lot more about trying it, engaging people, trying to get them to even take one step. And certainly you need persistence for this. This is not an easy addiction to overcome. It's rare that a person is successful the first time. The literature used to suggest that people needed to quit about 8 times before they were ultimately successful, but some new data suggests it's more like 30. You know, behavior change is quite hard. It takes a lot of energy and effort and persistence. This is a chronic condition, and we really have to be there to encourage people to try again and again and again. And what you notice when you do this work is that, you know, someone quits for 3 days, then they quit for 6 weeks, then they quit for 6 months, and they may have lapses in between or even relapses, but that ultimately then those people do go on to succeed for a long term. And sometimes, like I said, it takes several attempts to get them there. So these theories of co-occurring disorders, I think, are so useful and hopefully very familiar to you, because this is really a great frame for thinking about tobacco. That ideally we should be providing tobacco services that are integrated into what we're already doing in behavioral health, that services can take a long-term perspective. Not everybody's ready to quit tomorrow, and that's okay, but we should all still be working on it and trying to move forward. Some people are more motivated than others, and we could match our counseling strategies to people's motivational level. But again, taking this long-term perspective and working with everybody on this issue is really the most successful approach. Even when nothing is working, because these are difficult clients, we can always do assessment, and assessment helps us gain greater understanding, may help us with the therapeutic alliance. Motivational interventions work for this problem. Medications, interestingly, work. And it's interesting that in co-occurring in other substance use disorders under the co-occurring umbrella, that when you involve the external services like the support services of the case manager and the housing, that in fact people end up to have the greatest success in their sobriety. And it makes sense that that would also help for their tobacco problem as well. That if the case manager doesn't think that their job is to take people to the store to buy tobacco, that will be really useful for the overall plan. And you can imagine that smoke-free housing really supports this overall working towards being smoke-free. So this model, I think, is really useful for tobacco in addition to other drugs. So I talked really fast, and we covered a lot of different information. I'm happy to take questions now. But just to conclude, treatment works, and we should really be trying to engage people in treatment. And that can mean different things for different people. Not everybody's immediately ready to quit, but we can still help people to set goals, to reframe the language of treatment and what that means, to help people actually work towards taking action steps like having a quit date. We can always do assessment. Counseling and medication works. And again, themes that I kind of go over and over again is really think about it like a co-occurring disorder. I think that helps familiarize it and makes it more consistent with the other work that we do, and makes it easier to think about integrating it into our everyday work. I am going to stop and take questions, but before I do that, I just want to also mention that this is part of a larger project that Nancy referred to as TCTTAC, which is funded by the city to provide training and technical assistance on this issue for behavioral health providers in New York City. We have a website with additional resources that may be helpful to you that you could check out. People are asking for forms and tools, and a lot of them are available on this website. These facilitator guides are sort of bullets where they go through kind of the key aspects of how to do some of this work, similar with what we went over today. And then if you go into the CPI learning community website, there's now actually, this has to be updated, but there's now an icon for tobacco where you can link directly to that and find additional resources and tools and archived webinars for additional educational information. So Nancy, let me jump to you in case you want to say anything else about the LMS.
I think you covered that quite well, and I would just let you know that there were a couple questions that came in the chat box while you were speaking. One was asking about hypnosis, and the other asking or noticing that people are using e-cigarettes and feeling that that's a form of harm reduction.
Okay, so I often get asked about hypnosis, but at this point in time, hypnosis is not an evidence-based practice for quitting smoking. What does that mean? That means that when people try to do studies and they give people hypnosis, and they also have to have a control group where people are not getting hypnosis, that you can never really prove that hypnosis works. And so at this point, it's not considered an evidence-based practice. There's not research to support that it actually works. So I don't typically recommend things that are not evidence-based practices. Often people say, well, I know somebody and it works for them. You know, whenever something works, that's great. But as a general rule, we try to stick with the evidence-based practices, and we currently don't have evidence that hypnosis works. The other downside to hypnosis is that it can cost hundreds of dollars. If you want to go to somebody in the community that offers it, it's actually quite expensive, and at this point not proven to work. So I try to steer people towards the evidence-based strategies. E-cigarettes is quite a tricky answer, and so like anything in life, there's pros and cons, and the idea of an e-cigarette is actually not a bad idea, because most of the toxicity that we get from smoking comes from smoke, and the idea that the tobacco burns and that the combustion of that creates most of the toxins and illnesses associated with tobacco use. So the idea of an e-cigarette is, could we come up with a device that gives people nicotine but without smoke? And would people be better off from that? And we don't have a clear answer as of yet. In general, that's not a bad idea, but of course, the devil is in the details. And the e-cigarettes that are available today in the community, there's thousands of different products, so it's hard to generalize. And at this point, the government doesn't test or regulate them in any way. And that's an area of concern because you don't really know what's in them. Some of them use refillable e-juice, liquid that you put into your e-cigarette that contains nicotine. And there's evidence that that has some contaminants in it, and it has low levels of carcinogens. So maybe e-cigarettes are less risky than smoking, but you can't really say that they're not completely without risk. Because there's a lot of risk of the unknown, and you can't be really sure what's in them. That's one area of concern. Another area of concern is that they're cheap electronics that nobody, again, is testing or regulating, and they have exploded in people's faces and caused some significant burns, so perhaps that's an area of some concern. And the third issue I would bring up is that, you know, if you're allowing people to come into your treatment center and using e-cigarettes or even encouraging them to use e-cigarettes, I would be cautious about that because you wouldn't be able to tell if that person is actually vaping nicotine or vaping cannabis or any other drug. So it at least has the potential to bring other drugs into your environment, and I would be cautious about that because you can't tell from looking at the device what the person could be using. So it's kind of a slippery slope and an area of a lot of question, and really, again, usually we want to recommend that people use the safe and effective treatments, the things that have been studied. Again, in New York, most of the treatments that I talked about are going to be free for people. They should be able to get medication for free with their Medicaid. They should be able to get counseling more or less from you for free. So try to steer people towards the safe and effective evidence-based strategies is my usual rule.
Thanks, Jill. I have another question for you. Could you be more specific about support? What does a person have to do to support somebody?
You know, it's hard. I don't know if I have a great answer for this. I think it can be a lot of different things. You know, if you are surrounded by people who use this drug, and it's part of your social norm because your friends use it, and it's not really frowned upon, that will really undermine your success. So as much as possible, you want to identify with people that don't use the drug, whether, again, and when you think about that in terms of relapse prevention, what people talk about is your people, your places, and your things. The people that don't use it, the places where it's not used, the things that remind you of the drug, that all those things do seem to matter. And so whenever you can get support for that, to be around people that don't use the drug or places that don't use the drug, it's going to help you ultimately to be more successful, also by reducing your risk of cues. So it's sort of probably both. It gives you a positive, but it's also removing you from a negative risk for cue and relapse. So not a great answer. It is a bit nebulous, I admit. It can take lots of different forms. And again, I wouldn't consider a lot of internet websites as treatment for tobacco. To me, that's not treatment. But I think it could be a great source of support where it's supplementing your treatment with something else, checking in with the patient, giving them emails, giving them access to another network or chat rooms, and those things can really enhance the treatment that you're already providing.
Okay, well, I think we're right at 4 o'clock, and I want to thank you very much, Dr. Williams, for such a great presentation as always, and hopefully folks see that they can download the slides and the Learning About Healthy Living manual, and I don't know if you have any final words that you'd like to say.
I see that there were a couple questions about assessment, so let me just very briefly say there's lots of different examples out there for assessment instruments. There's not one right or wrong way to do it. We can send examples if that's helpful to the group. People talked about the Fagerstrom, and there's also an assessment tool in the Learning About Healthy Living manual, so there should be lots of examples that people can draw from.
Thank you very much. And
thank you, Nancy.
Thank you, everybody, for joining. It was a